So good afternoon, everybody. This session is on dreaming about an ideal response to mental health and suicide crises as a response to COVID-19. My name is Sarah Kolbeck. I am the director of the Division of Suicide Prevention at the Comprehensive Injury Center at the Medical College of Wisconsin. And I will let my co-presenter introduce herself.
Hi, I'm Sarah Bassing-Sutton. I'm the Community Suicide Prevention Coordinator with the Northeast Wisconsin Mental Health Connection, located in Wisconsin in the Fox Valley.
And before we get started today, we just want to have a couple of acknowledgements. First, we'd like to acknowledge Beth Clay from the Northeast Wisconsin Mental Health Connection, who the Northeast Wisconsin Mental Health Connection is the agency that is driving the work that we are doing. And we would also like to acknowledge Dr. Steve Hargarten, who is our moderator for the session and on the call with us this afternoon and will help with questions at the end. So thanks to both Beth and Dr. Hargarten. And we also want to acknowledge that this project is funded through the Advancing a Healthier Wisconsin Endowment at the Medical College of Wisconsin. And so the objectives for this afternoon session. First, we're going to summarize Project Zero, which is the grant-funded work that we are conducting in the Fox Valley region of Wisconsin. We are going to talk through some of the changes that we had to make to Project Zero as a result of COVID-19. Many of those had to deal with increasing distress in the community and corresponding increases in calls to law enforcement. We're going to be describing data that we gathered through our early warning system, and then talk about the ideal system response that we developed as a result of the data that we were analyzing and witnessing through the early warning system. And then we will wrap up by talking about some of the next steps for our project.
So Project Zero is the grant through which I'm employed, and my position is a collaboration between a county public health entity and the Northeast Wisconsin Mental Health Connection, which is a backbone agency for mental health and works through collective impact in our Tri-County area. So you can see in the little circle there, that is the area in which I live and work. And Project Zero serves the Tri-County, so Outagamie, Winnebago, and Calumet counties. And the adult population in that area, you can see listed here. The demographics is a pretty even split between men and women. And over 90% of the population in this area is white. So Project Zero was created due to recognizing a 66% increase over the past decade in suicides in the Tri-County area. And the big goal is to reduce suicides among working age men who have the highest demographic or the highest suicide rate in our area. So the goals and strategies of Project Zero include further embedding the Zero Suicide Framework into the healthcare systems as well as the behavioral health organizations. Another strategy includes awareness and enhancing just overall community support for suicide prevention, making it less of a taboo. And the third strategy and goal is to improve the quality of suicide data that's collected to better inform prevention. And Project Zero got its feet and was launched in January of 2020.
And then, as we all know, in March of 2020, COVID-19 hit. We had just several weeks before COVID-19 started to shut things down, had our first strategic planning meeting for Project Zero, and felt like we had a pretty good idea of what our next steps were as they were aligned with the three goals that Sarah mentioned on the last slide. And then, of course, we had to pivot. The hospital systems and public health agencies that we were working with they just didn't have the capacity to do things like implementing the Zero Suicide Framework at that time, or putting together and attending suicide review commission meetings. They were very, very focused on responding to and managing COVID-19. And in addition to that, we also saw in our community that what we were facing was really a perfect storm of situations and contexts and circumstances that could really lead to some pretty significant mental health issues. And you can see here on the screen, and folks, I mean, are aware of these, in your own lives. But when COVID-19 really, emerged as a big issue, we saw a decrease in protective factors, including, things like connectedness, us, all having to kind of retreat to our homes, losing our routine, potentially even losing our jobs, lots of closures and things of that nature. So those protective factors were decreasing rapidly and sometimes immediately, while at the same time, there were risk factors for mental health issues and suicide that were increasing, including, as I mentioned, job loss, increase in use of alcohol, and even an increase in access to lethal means like firearms. And so we had at the beginning and throughout the COVID-19 pandemic, really this perfect storm for mental health issues. So not only did we see as Project Zero that our partners were really unable to continue with the project activities as we had outlined, but we also saw in our community that there was this emerging need and increasing distress to which we really needed to respond. Here's some other just statistics about the impact of COVID-19 on mental health. About half of adults have said that COVID-19 has a negative impact on their mental health, while about 1 in 5 have said that COVID has had a major impact on their mental health. A majority of adults who lost income report worsened mental health. And anecdotally, there was a 50% increase in local police contacts for mental health crises and suicide-related behavior, along with an almost 900% increase in calls to SAMHSA's disaster distress hotline. So while we had these decreasing protective factors and increasing risk factors, we see that in these numbers as, the distress among community members really rising at the same time that a lot of our support systems were kind of needing to be put on the back burner. And so, as I said, Project Zero was really just getting off the ground, but we really needed to pivot. As I said, our hospital partners and our public health systems were fully immersed in COVID and their COVID response and really weren't able to engage. At the same time, our law enforcement partners in the Tri-County region were really reporting significant increases in changes and calls for mental health or suicide crises. As the primary responders for these calls, they were just really feeling overwhelmed by the number of calls that were coming in. Community members were losing jobs, access to regular health and mental health services, and schools were moving to virtual. So the world was really changing. And so it was really on us then as a project team to think about how might Project Zero help.
So that led us to the creation of this early warning system. Like Sarah said, it was a perfect storm, and we recognized that early on and created this partnership with law enforcement to monitor in our community what was happening with our adults and just overall community related to mental health, suicide ideation, suicide attempts, and deaths by suicide. So the early warning system, like I said, was a partnership with law enforcement and having ongoing conversations with them about the calls that are coming in and collecting data about those calls so that we could ascertain whether or not we needed to be doing something different and really to get ahead of the curve rather than be behind the curve. So we started collecting data related to sex, age, race, time of day, and date of call, primary and secondary factors that would trigger the calls to law enforcement, as well as general location, whether something was happening in someone's home, in the road, near the tracks, just a general location. And we were also having regular contact with our coroners to keep an eye on the overall number of suicides that was happening in our community, and just in connection as well with our community crisis to see if their call volumes were increasing as well. So here's a look at the data from the beginning of when we started collecting calls to law enforcement and what that looks like from March 13th, when everything kind of shut down, to the end of November. And during this time, the volume of calls to law enforcement for mental health or suicide-related crisis has roughly increased 60%. And most of these calls that law enforcement has been fielding was related to suicide ideation. You can see that almost 70% of those calls were related to thoughts of suicide. And it's important to note that these calls do not include any of the deaths that were still pending. It does not include information about single vehicle accidents or overdose deaths. So these calls are strictly related to mental health calls that either rose to the level of ideation, a suicide attempt, a mental health crisis, or death by suicide. So quickly, we recognized that there was a problem.
In terms of some of the other data that we were able to look at, we noted that most of the calls that were coming into law enforcement were received in the afternoon and evening hours. And you see the percentages of calls by both day of the week and time of day broken down here. There wasn't really one specific day of the week in which, there was a higher frequency of activity than other days. Certainly you can see Wednesday had the most calls, but nothing really stands out necessarily as an outlier. But we did notice in terms of time of day that most calls coming into law enforcement were being received in that noon to midnight time period, kind of that second shift, early afternoon into second shift timing. And this was really important for us to know and understand because this information could be used and is being used to help drive the response to this in a way that allows us to know when to sort of augment staffing to make sure that folks are available when people are calling in. Another thing that we also noted is that there was a fairly even split between male and female callers, slightly higher percentage of males than females. And we did have a couple of transgender folks that were calling into to law enforcement as a result of either a suicide crisis or a mental health crisis as well. One of the other data points that we gather is mechanism of injury. Not always, but sometimes when folks make a call to law enforcement for a mental health or suicide crisis, they mention whether they're considering, taking their life with a gun or prescription drugs or some other mechanism. And so we gather that. So for the calls in which a person mentioned a specific mechanism of injury, you can see the percentage here. So of those that we were able to note, about 1 in 5 were prescription drugs, followed by sharp objects and firearms as well. Obviously, this is a concern. Firearms are a very lethal mechanism of injury. And so, understanding kind of how people are contemplating attempting suicide is really important to make sure that the response is appropriate. As Sarah mentioned, we collected information on kind of the primary events or activating factors that led to prompt a call to law enforcement. And as you can see here, the top 3 issues that were mentioned by callers was, a mental health crisis, followed up by relationship issues as well as substance misuse. So roughly half of the callers, their primary concern was a mental health issue, but about a quarter were relationship issues, and as you can see here, 12% substance use. We did also collect some information about COVID and whether or not COVID was related to kind of the primary concern, and we certainly did see that in some of the calls. COVID was mentioned as either a stressor or job loss due to COVID, but definitely that by and far the largest percentage of callers referenced a mental health issue. We also were interested in looking at data by age group. So again, we would have good information for prevention. And here you can see calls by age group over time. The darker blue are kind of the working age adults, ages 25 to 54. The grayish color are youth and young people, ages 10 to 24. And then the lighter blue reflects calls over time for folks ages 55 and older. And we did actually see a slight decrease in calls from youth over time. We felt that there were quite a few calls initially as the pandemic kind of was unfolding that started to taper off a bit over time. And at the same time, we did see a slight increase in calls from folks ages 55 and over. But overall, most calls were received from those working aged individuals ages 25 to 54.
So what to do with all of this knowledge that we had acquired and data that we had collected over the course of a number of months and hours of working with law enforcement? So one of the things that resulted from all of this data gathering was the creation of our dream team. And the dream team was really charged with dreaming up what the ideal system response would be for folks in mental health and suicide crisis, recognizing that perhaps we don't always have the right people in the right place at the right time. And so since everything has changed, how do we go ahead and just capitalize on that and change everything? How can we be innovative, and how can we really insert some things into our systems of care that might be beneficial for the entire system as well as the community? So our multidisciplinary team consisted of folks from law enforcement, mental health professionals, county crisis, our academic partners, as well as the most important voice of lived experience at that table. We had a number of tabletop exercises where we had everyone at the table walking through scenarios of mental health and suicide crisis, where it started to where it ended. And there was an education amongst community partners in this system of care that was really well informed and elevated because we had that voice of lived experience at the table. And so our dream team really continued to work together over a number of months to create the ideal system response in our community for mental health and suicide crisis.
And so to kind of get us kicked off with our dream team work, we really wanted to think about, what, as Sarah said, what this ideal system response would look like. And in order for us to do that, we put together the logic model that you see here on our screen. And really the goals of this ideal system response, you can see in the far right column under long-term outcomes. Really the goal was to have a non-punitive, culturally humble response to suicide crises, and an increase in trust among community members in this crisis response. We also wanted to make sure that community members in distress had more rapid access to immediate health services, including appointments with clinicians or other resources as needed, safety planning, things of that nature. And then we also really took into account, how we are responding to deaths by suicide. And so we really wanted to mitigate the negative impacts of suicide on family members, loved ones in the community after someone dies by suicide. And so stepping back then from those long-term outcomes, if you look in the column that says medium outcomes, we really were looking for an increased involvement of community agencies in response to these crises, while at the same time decreasing the involvement of law enforcement in response to suicidal crises. One of the things that our dream team discussed at length, especially with lived experience at the table, and that voice, was how potentially damaging this response can be and punitive. And so really thinking about how we can involve law enforcement in this response in a way that makes sense. And is informed by the voice of lived experience. We also wanted to make sure that folks were using resources that are available to them in the community, and then having a more collaborative deployment of resources to loved ones after a death by suicide. In terms of short-term outcomes, we really wanted to increase the competence of community agencies to respond to crises in a way that's coordinated. Each agency has their own response, and we wanted to make sure that that's more well coordinated than it is now. Increasing competence of all involved agencies to provide a safe and least restrictive response to suicide crisis. That was really something else that we discussed, is how can we make this the least restrictive option possible? And you'll see that in upcoming slides, how we sort of operationalize that. We wanted to increase awareness of available mental health resources, including open appointments and available mental health beds, and then really improving communication between law enforcement, community crisis, and other resources and specialists when a suicide does occur. And then you can see on the left-hand side of the logic model, our inputs, our outputs, and then the participation that will lead us to these various outcomes. And so we, oh, sorry, Sarah, go ahead.
That's all right. So we'll go ahead and take a look at what the ideal response was that the dream team came up with. And it's in 3 segments, if you will. So this first look will be at first responders. And what we recognized as we were all together at the same table was that this one-size-fits-all solution for law enforcement to be responding to mental health calls is inefficient, it can be ineffective, and at worst can cause poor outcomes. And one of the things I want to share is we have a number of CIT trained officers in our area. So we have some very well-equipped law enforcement, and unfortunately, these can still be some of the outcomes related to law enforcement responding to a mental health crisis. So as we look at calls that would come into 911, we talked about and created a tiered response with the goal being de-escalation and a direct connection into treatment and support, which ultimately creates a safer environment for our community members as well as for our law enforcement. So this is a look at the flow chart of what that looks like. And one of the things that the dream team developed first before any of this, you'll see in the box at the bottom is the guiding principles. So the first thing we talked about was, how do we want this system to respond? What does that really look like and feel like? And so you'll see those guiding principles listed on each of our flow charts for the ideal system response. So the green arrows are the things that exist, and the things in orange are items that are part of the ideal system. So currently, when law enforcement or when 911 is called for a mental health crisis, right now law enforcement responds. We do have county crisis that works with our law enforcement, but in a tandem sort of way, not necessarily a partnership sort of way. So the ideal response would consist of tier 1 for folks with vague suicidal ideation. Potentially, it could be just a referral to a warm line, talking with a certified peer specialist. It could involve this MHN, which stands for a mental health navigator, that could assist someone in getting connected to an open urgent appointment for the following day, or just creating a safety plan. Tier 2 is perhaps someone with a suicide plan, but no access to lethal means and no prior attempts. So there would be some triage involved in this 911 call that doesn't currently exist. And you can see what the response to that would look like, which would include some specially trained victim crisis responders, that's what VCR stand for, who would be able to assess and manage safety planning. And then in tier 3 would be a law enforcement response to make sure that the scene is safe, but also having that mental health professional and or a peer support specialist available to address the care management component of that situation. And the mental health crisis assessment has only 2 tiers. And no matter what that response is in the tiers, we would have these caring contacts as a part of our ideal system response for first responders, that someone would follow up with the individual the next day that was in crisis to ensure that they have gotten what they need, to ensure that they've gotten an appointment, and to make sure that they are able to attend the appointment that they're scheduled for.
Another component that our dream team tackled in terms of an ideal system response relates to the context and the situation that is faced by consumers in the emergency department or the emergency room at the hospitals. And so we know that more and more community members are going to the emergency department seeking help for mental health crises for several reasons. Either they don't have access to a mental health provider, or they don't have insurance, or they're just not sure where to go. There are a lot of patients, a lot of community members that go to the emergency department for help. But resources are strained in the emergency department setting. Staffing is stretched and expertise is unevenly distributed. There's not necessarily a mental health professional working in the emergency department at all times, or even a social worker potentially. And so, there may not be the necessary expertise at the emergency department at the time a patient comes in for care. And at the same time, sort of a team approach to managing mental health crises in the emergency department has yet to be fully implemented. And so the dream team sort of reimagining of a response within the emergency department setting includes a team that has certified peer specialists, concurrent processes of medical clearance and connections to care, and improved services that may allow for the avoidance of ED services altogether. One of the things that we heard in our tabletop exercises was that this time in the emergency department is, from a law enforcement perspective, very challenging, from a patient client perspective, very challenging, and also challenging to the emergency department staff. So we were really hearing that the status quo is not acceptable in terms of the current kind of the status quo of the response as it is today. And so here is our ideal system response. So this is similar to the flow chart that Sarah presented on the last slide. We have our guiding principles up at the top right-hand side of the screen, but you can see that there's a number of different approaches here. So a person will choose to go to the emergency department, and when they make that choice to present to the emergency department, they sort of bypass the lobby waiting area situation that can be really loud and distracting and distressing for a person that's having a mental health crisis. They're immediately brought back to a mental health exam room that's been designated as such within the emergency department. And then they're joined by somebody like a certified peer specialist who is either employed by the hospital or by an external community agency that's really meant to sort of help them understand what's happening to them, help them understand what choices and decisions they need to make, and really just be somebody that can sit there with this person during this crisis. At that point, there would be contracted mental health providers or someone from the behavioral health unit that would immediately be able to come to the emergency department and speak with the individual in crisis, and then professionally assess and assist in their decision making. It's possible that this person does not need to go inpatient, and so what are their other options? Perhaps they're offered an appointment the next day through the mental health navigator, an appointment with a clinician, or perhaps they're offered information on a local peer-run respite that might be a better solution for them than inpatient hospitalization. In the case that someone is hospitalized, either voluntary or involuntarily, the mental health navigator is really involved in contacting hospitals to ensure that there are available inpatient beds while the patient is going through the medical clearance procedures that they need to go through to be hospitalized. And finally, there's a non-law enforcement transportation provided to the facility that has an available bed, so that the person in crisis is not going into the back of a police car in handcuffs, potentially with a uniformed officer to the hospital, but there's a more trauma-informed response.
So the third section of the ideal system response that the dream team talked about and looked at was...
Sorry, I just lost the slides here.
Related to a death by suicide and or a sudden death. And we really talked about how in our community, the current response is very disjointed. And at times, it is the luck of the draw what you get in that response.
Sorry, I'm almost there, Sarah.
That's all right. I just don't want to.
My internet just kind of, here we go. Okay. I have to share my screen again.
There we go. So like I was saying, disjointed and inconsistent. So we wanted to look at how can we, as a community of professionals, respond in a way that is both immediate and consistent. And it's not a luck of the draw who you get on the scene, but really each sector of the community knows how each other sector of the community of professionals will respond and wrap around individuals who are survivors of a sudden death or a death by suicide in a postvention sort of way to help those who are on the scene and those who are surviving the death of a loved one by suicide, as well as a way of having a standardized data collection process that better informs prevention and intervention. So when we looked at the flow chart for this part of the system, again, the green arrows are what happens and the orange arrows represent things that would be ideal system response. So when there's a death by suicide or a sudden death, sometimes friends or family or a chaplain is there, but who's always there is law enforcement, EMS, and the coroners, who have a job of focusing on the scene at hand. So their job is risk management. In our community, we have victim crisis response, and some of our jurisdictions utilize the victim crisis responders for death by suicide. And their job really is care management on the scene. So their job is to be with the people who are trying to wrap their head around what just happened. And we developed the idea of what could come from this response, which would include some safety planning that the victim crisis response team does now. They also provide resources to family and friends on the scene about what is happening, what's going to happen, what's the procedure with the coroners. The mental health navigator would be a huge piece of this ideal system response in being available for the victim crisis responders to contact if the family members were at that time interested in connecting to the mental health system of care. And then from the risk management and scene processing end of things, we think that the ideal system response would also somehow involve the information being passed along to that person's therapist if they had one, the county crisis if they were involved in that situation, or even the primary care physician to wrap around, again, that family and the community and all of those who are impacted by the ripple effect of a death by suicide or a sudden death. And our suicide prevention agencies are another critical piece of the ripple effect and what their role could be in assisting schools or employers of said individual. And then the suicide investigation form, which really is another critical piece of standardizing the data collection and informing prevention and intervention. And if we had this as a institutionalized component of how we respond when there's a suicide death, we would have a plethora of information to better inform how we are doing intervention and prevention. So an ideal system response to a death by suicide would really better prevent contagion as well as support survivors.
And so, oh, Sarah, this is you. Sorry,
Nope.
Go ahead.
So the projected outcomes of our ideal system response really involve solving rather than managing ongoing issues, if you will. So we anticipate that if we were able to implement all of these things, or even components of this ideal system response, we're going to see a decrease in the things that we want to see decreases in. So deaths by suicide, ED visits potentially, poor outcomes from inefficient and sometimes inappropriate responses to mental health and suicide crisis. And we're going to see an increase in the humanitarian benefit. So there will be a response that will be compassionate in a way of having the right professional in the right place at the right time, and the follow-up to ensure that people are engaged in the mental health system of care, as well as an increase in diversion options and resource utilization. So when we see all of these increases and decreases in the right area, there's cost savings. These mental health crisis calls are very time consuming for law enforcement, as well as involuntary holds and sometimes the cost across the system in those ways when people don't necessarily need to be hospitalized involuntarily. And through this ideal system response, there would be more options presented to individuals in crisis, and they would be an active participant in that care planning in a way that doesn't necessarily happen today. So again, this would be solving rather than managing. So where are we now as a result of all of this data collection and ideal system response planning? We have continued to meet and to work in implementation groups, if you will, related to these different sectors of the ideal system response to generate or capitalize, I should say, on the energy and synergy of this work to look at some implementation of these innovations. So one of those is a co-responder model. As I mentioned before, we have a number of CIT trained officers in our area who are incredibly compassionate and do the work with a great deal of care. And this opportunity has opened the way to embed a clinical therapist in our Appleton Police Department that can respond along with law enforcement so that once the scene is determined to be safe, the clinician can then go in to help de-escalate and assess, as well as make a plan for care right on the scene. So there's no need to transport a person to the emergency department for a crisis counselor to come and provide the assessment. It can all happen in one place at one time and will make the event more safe for law enforcement, as well as the clinician, as well as the community member. So it really is an opportunity to have a mental health response to a mental health issue.
Another component that we are working on implementing is regards the response to a suicide death and kind of the post-vention component of that. And so as you might recall from the flow chart we had around suicide deaths, one of the components that we felt was important was to have a response by victim crisis, by the VCR victim crisis response team. You know, it's important for law enforcement and the coroner medical examiner to be able to sort of secure the scene of a suicide and then conduct their investigation. And while they are doing that, you know, the victim crisis responders would really be able to provide care management to the family or loved ones on scene, while law enforcement, as I said, is really providing that risk assessment and processing the scene. The victim crisis responders can also provide resources to family members and loved ones at the scene and answer questions at the moment. These victim crisis responders are experts in community resources and in managing this sort of a situation. You know, they currently respond alongside law enforcement for criminal and crime-related calls, but leveraging those skills and that knowledge for suicide death would also really enable kind of as I said, the diversion of resources in the moment to folks that are dealing with a death by suicide. The VCRs would also conduct some follow-up with survivors of suicide loss in the weeks and months following the event to connect them to resources. You know, certainly understanding that the needs of these individuals are going to change, you know, the less proximal they are to the actual suicide death. And so ensuring that folks, survivors in particular, have access to the resources they need as they cope with the loss of a loved one. Additionally, part of this postvention strategy is really meant to reduce suicide among survivors. We know that individuals who experience the suicide of a family member or a loved one, that places them at risk for future suicide themselves. And so this VCR response would help sort of mitigate that risk by providing resources, on an ongoing basis. One of the things that we're also doing as part of the evaluation for this is tracking outcomes for those individuals or survivors who received VCR intervention versus those that have not, to look at the difference really that the insertion of this intervention makes not only on the system, but also on the survivors of suicide loss who are potentially facing some pretty serious outcomes without that intervention. So we'll be looking at both those who received VCR intervention and those who did not.
And the other piece that we are looking to implement is the mental health navigator, which you saw throughout each of the sectors of our ideal system response. And the mental health navigator has changed shape and form throughout this time of trying to implement this concept. And essentially what the data and the research has shown us in our community is that the issue that we are attempting to solve by having a mental health navigator is to assist law enforcement in having a resource and a tool that they can distribute to people who are in crisis that don't meet the need for inpatient or any other additional services, but it's a phone number that they can give to individuals that will allow them to contact somebody and someone to contact them to help them get connected to the mental health system of care and access open urgent appointments either same day or next day, and to really determine ongoingly the community mental health provider capacity for these open urgent appointments. And the goal with this is for both law enforcement, who has been our greatest partner in all of this work, to compassionately and quickly connect folks in crisis to the least restrictive care in that moment, whether it's mental health, AODA, or suicide crisis.
And so in terms of next steps, one of the things that we talked about when we were going through this, kind of planning and dreaming, I guess, for this ideal system response is that, we're not going to be able to change the entire system, that this is going to require, thinking about how to actually operationalize some of these, quote unquote dreams that we had. And so really our approach has been to have these different pilots and interventions, such as the clinical therapist co-responder or the VCR response or the mental health navigator response, and sort of drop these interventions into the system and see how the system reacts to these different interventions and how, more importantly, consumer outcomes are affected by these different interventions that are introduced into the system. And so our next steps for this, from my perspective as the academic partner on this grant, is really thinking about evaluation and helping to make the case that, these different interventions are improving some of the outcomes that we are concerned about in the community right now, particularly as it relates to the consumer or the client in the system. We're evaluating the different outcomes, we're really paying close attention to the voice of lived experience, and we're fortunate to have the voice of lived experience at the table in our planning and our evaluation as well. So that is ongoing. That evaluation has started for a number of these different indicators. We're starting to gather some baseline data, both qualitatively and quantitatively, so that we can look at how these changes are unfolding across the region. Sarah, I don't know if you want to talk about funding and community support.
We can. Do you want to, I think the next couple of slides tie really well into that.
Okay, great.
So one of the ways that we have started talking with funders in our area is about this new practice of problem solving. And it comes from the Stanford Social Innovation Review. And it has 4 main elements. One being it's people-centered, really looking at why we would do systems change. Then next, as Sarah mentioned, the data. So really making data-driven decisions and learning about why it is a problem. And 3, experimental. So what other, the research component, what other models exist? What concepts do we have to pull from? And how do we pilot something like this? And from those experimental aspects and the piloting, designing to scale then. So starting off small, learning what we learn and kind of building it as we go. This has been the framework that we have been talking with funders in our area about, to really bring them along on this journey of the ideal system response and having them be a partner in this development and a partner in what it looks like in the end, so that they really feel informed and a part of the process.
And the way that this looks like in practice with what we're doing, so we are looking at this component that's people-centered and data-driven in regards specifically to law enforcement contacts in the time of mental health and suicide crises. We know that at present, folks are not being connected to treatment. However, we also know that we have open appointments within the community setting. And so how do we create that connection? Again, it's inserting an intervention into the system to facilitate that access to open and urgent appointments. In terms of experimental, we know that we need a mental health navigator to connect those in crisis to same day or next day appointments in a no risk way, no risk in terms of the agencies that are engaging in this solution. And so what we're doing is trying to figure out how we can redeploy existing call centers to take calls from law enforcement and then make that connection to care. So that is currently happening in our community. Designing to scale, we have a couple of call centers, one at Theta Care for adults and another at Catalpa for youth. We also have behavioral health for 24-hour coverage. And so open appointments were a time-bound phenomenon. And there's a return to these access challenges and accessing these appointments. So thinking about now what, how do we scale these ideas up? And then finally, learning from the sample contacts that we've had, the complexity of the needs involved in police contacts. We know that there is a need for case management to get those who are in crisis really to care. And so our question for us is how can we find community-based case management to receive a handoff from law enforcement? And we're currently engaging in those conversations with a local agency now to operationalize this sort of mental health navigator role, case management role to help make some of these connections in the community.
All right, so just a reminder that, oh, you're finished, or
Yep.
You have 2 minutes left, so that's pretty good timing.
Thank you. Yeah, so, oh, and I just lost my slides again. My internet keeps kicking me out, but that's okay. We're at the end of the presentation. So if there's any questions.
Sarah, there's a question about how do you see this coordinating this whole dream concept, both for both Sarahs? How do you see this coordinating with 988 system?
Sarah, you want to take a stab at that?
Yeah, so the 9888 system is the new crisis line for mental health emergencies, like 911 for physical health emergencies. And so I think that this will have to be a conversation with figuring out exactly how those calls are going to be received and who's triaging those calls. You know, based on the tiered response that we showed, especially with the calls to law enforcement for a suicide crisis, you know, I think really working with the existing resources in the county, again, to think about how those calls are being triaged, who's answering those calls, and then ensuring that the appropriate responses are deployed. You know, I think it's going to have to be a conversation with folks in the county. Sarah, I don't know if you have other thoughts, but.
The only other thought I had was we do have a member of our dream team that is also part of the 988 implementation in our area. So he is on both of those teams, which I think is really going to be helpful for us too in being informed on how that is coming in and how our ideal system response can coordinate with that as a part of our overall community system response.
All right, well, looks like it's winding down. We are out of time, so I want to thank both of you for presenting here. I don't know if that's my responsibility still to thank you for what I'm doing for this all.
Well, you're welcome.
You are welcome. And if anyone has any questions, feel free to email us.
Yeah, they can apparently message you on Hoova too. That's a
Great.
feature. They can ping you. There's a series of things that they can do. So
Wonderful.
Wonderful. We're happy to answer any questions.
all right, well, I'm gonna end the session.
All right. Thanks, everyone.
Thank you.
Thank you.
Everyone have a good day.
You too. Bye-bye.